All right, this is going to be part 2 of my pulmonology series. All right, this is a kind of like a risk factors question. This respiration rate is really odd. All right, seems like a pretty typical code, although she is rather tachypnic. Probably just a viral thing. Um, yeah, neonates are at a really high risk for apnea for whatever reason. Bacteremia is not super common. Yeah, there are increased risks for bacteremia and bacterial pneumonia too, but it's not as pronounced as it is in adults, and apnea is just far more common. Yeah, so bronchiolitis is. All right, so this is RSV bronchiolitis, and it seems like pneumonia is actually not associated with this at all. Okay, that's interesting. I wonder why. It doesn't really explain why. I guess it's just an observed change that they've seen. Management question, pediatrics. Vague chest discomfort, and it seems like there's some kind of atelectasis going on in here. Doesn't look like an infusion. I'm not going to place a chest tube for that. No thorax either. CT scan, no, you wouldn't need that. I don't think he perforated or anything. Wait, did he perforate? Wait, no, he might have perforated. Yeah, you know what? He probably perforated. All right, in that case, you need to get a CT scan to see exactly where the perforation is. I thought this was kind of atelectasis due to contusion, and it could still be that. Um, yeah, except for I just don't think that you would see such a bizarre distribution. And this kind of looks like intestine to me. Yeah, these are bowel loops. And there's kind of shifting the mediastinum too. Okay. Yeah, I guess an important thing to note is that children with traumatic injury can present with months to years later with progressive expansion of diaphragmatic defect. Kind of makes sense given that they're still growing and that, you know, maybe they don't have as high intra-abdominal pressures as adults do. I think I got this question wrong the first time because I just didn't think that, I didn't think that, yeah, I just thought this was atelectasis when it really wasn't. 25-year-old diagnosis, hemoptysis. All right, I have no idea what this is, but this does look quite suspicious. Squamous cell, no, he's not a smoker. Small cell, you'd be pretty unlikely to get it this early, and it's not to form such this kind of a mass. Tuberculosis, this is kind of too acute for that. You'd also see other findings in the CT. So yeah, I'm gonna go with bronchial carcinoid tumor. Yep, which is the answer. Arise in the proximal airway, airway obstruction, hemoptysis, avidly enhancing mass. Management, 65-year-old COPD. All right, so hemodynamically, there's something going on here. There's tracheal deviation to the right. Tracheal deviation to the left. So do you have a pneumothorax of some kind? Yeah, I think you might have gotten a tension pneumo. He either got a tension pneumothorax or he wasn't intubated properly, and the left side will be expanding if it's only in the left if it's only in the left bronchi. The bronchus. So you'd be deviated to the right. All right, good. So it is a tension pneumo. Management question, 45-year-old, sounds like pneumonia, ventilator associated, febrile, otherwise okay. What is this? Oh wow, look at that. Yeah, this looks like an abscess to me. You can see kind of air fluid levels in there. All right, so this is an abscess, and you need to treat this empirically. Now, where we know this is an abscess, there's no need to biopsy. Metronidazole and empiric. Metronidazole tends to cover anaerobes quite well. However, it does not really have good penetration into abscesses. Metronidazole above the lungs, clindamycin above the diaphragm, metronidazole below. Yeah. You guys could use clindamycin, but ampicillin, sulfactam, this would be the other. I think this is also pretty good against abscess. Good. Clindamycin's the alternative. Imipenem, meropenem are also good. Yeah, so this is just Unison. Silson is piperacillin tazobactam. Okay. I think I got it wrong the first time because I didn't think ampicillin sulfactam had enough abscess penetration, and I thought that metronidazole had good penetration when it did not. Would you give it for GI abscesses? Let me take a look. Yeah, I have no idea. Obligate anaerobes, but minimal effectively facultative anaerobes. Okay, I see. Maybe that's why, because I'm pretty sure metronidazole is still good for GI abscesses. Cough management, adult. The split second heart sound thing always kind of tricks me up. It's usually aortic, then pulmonic. So if you inspiration should be delayed, so yeah, that makes sense. If they expire, then APU should happen. Both of them should close at once. Doesn't really help the answer though. Just young person with cough. He's already on. GERD can cause cough, especially in children, but I don't think that's what's happening. A chest X-ray is normal too. I think he probably has some kind of post-nasal drip, honestly. Could be asthma, but just a cough variant of that would be pretty rare, especially at this age. Versus the night part is pretty interesting. Not really sure what they are pointing at by that. Maybe it's somehow positional, but no post-nasal drip. Okay, so it's not just allergic. Omeprazole, I don't think that's going to help. PFDs, could it be asthma? I guess, but kind of unlikely. Sputum microscopy, this doesn't sound infectious. Transthoracic echo, no, I don't think this is heart related. CT scan of the chest, maybe? I have no idea. I just look for a bronchoscopy, anything, just because it covers all the bases. In practice, I have no idea which one would be the best one. I guess it could have some like nasopharyngeal irritation or something, but that's it. It is PFTs. So it is asthma after all. Asthma may present with chronic cough that is predominantly nocturnal. Patients should be evaluated with spirometry or assess bronchodilator response. Okay, So I was wrong to rule out asthma in this patient. This age is not too young, and coughing at night is common even in young adults. So not even young adults, in like middle-aged people like this person. All right, so I guess don't count your chickens before they hatch. I don't think. Yeah, I ruled out asthma too quickly, and bronchoscopy doesn't really do anything here. Yeah, it has no role exactly, unless there's like a foreign body of some kind. Recovery question? Another ventilator question. These questions give me a lot of grief. I feel like I just don't know how ventilators work. Pretty acidotic. Recovery from respiratory failure. I remember this question. Alpha was the right answer. Avoiding a positive fluid balance to reduce pulmonary edema. But he is oxygenating okay, I guess. There is some permissive hypercapnia going on, but again, this is not too extreme. Tidal volume, how much is that? Typically, I think you don't want to increase the tidal volume too much, or you get ARDS. If I were to above 96%, no, you don't really need that. 92 is good enough. Yeah. All right. Hyperinflate the lung, no bad idea. Pneumothorax, deep coma, no, that's just counterintuitive. So permissive hypercapnia is well tolerated, okay? Yeah, I'm not sure what the science behind that is, but whatever. I'm gonna mark that as wrong too, since I didn't know what was going on. I just remember the answer. Treatment question? Might have had some kind of pneumonia. Oh, those are okay. But yeah, pretty bad respiratory distress, COPD, you name it. Pretty badly acidotic. Carbon dioxide trapping, the whole shebang. All right, so this is kind of a treatment question. Which of the following therapies is more likely to benefit this patient? So typically in terms of chronic therapies, you do a SABA or a short-acting muscarinic antagonist, then you do a I think it's like long-acting muscarinic antagonist, then you do inhaled corticosteroids, and yeah, so on and so forth. Let me just go through my book and double check that. Hmm. Let me go into my notes. I can't find it. Oh no, I was right. Oh, yeah, I was right. Actually, no, sorry. Or inhaled. Yeah, 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 I was right after all. Cool. All right. So exacerbation, you give antibiotics, you give fluids, you give short-acting beta agonists, and I think short-acting, whatever. I think steroids is kind of the mainstay of treatment for both methylprednisolone. That's oral, right? I think it's oral. Benefit the patient. You give oxygen, acetylcysteine. No. I don't even know what this is. Hormones. No. Fluticasone. Yeah, I give inhaled corticosteroids. Uh, Methylprednisolone. I'm pretty sure this is a in this is an IV medication. I don't know if you give it here. I don't think you would. Furosemide, no. Salmeterol, no. And this is long-acting beta agonist. But you don't give that without cortical inhaled ICS. All right, so acute COPD exacerbation. This is probably one of the most likely, most common conditions we see in the emergency department, and I messed it up. Inhaled bronchodilators and systemic glucocorticoids. All right, inhaled for long-term management in patients COPD or advanced disease. They do not. They, so acute exacerbation, you do not give inhaled corticosteroids. You just jump straight to IV ones, right? Yeah, you just give systemic therapy. I don't know if methylprednisolone is IV or oral. All right, it's both. All right, I guess that's good. Makes sense too, because I feel like you do the same thing for asthma patients. Damn, I went through this just literally earlier today. I thought I had it all down, but no. ABG. Sepsis. Probably sepsis from pylo. What is this? So she's oxygenating well, and she is. That's interesting. So it seems like, yeah, she's septic, and she actually has a slight respiratory acidosis. Respiratory, wait, no. Her, she's not really reacting to the acidosis, not really compensating for that. So there's kind of a metabolic acidosis as well as a respiratory acidosis. Is there an anion gap? Yeah, there's an anion gap too, so blood piles. The only one that makes sense to me is this kind of respiratory muscle fatigue. She's trying to compensate for the metabolic acidosis. However, she's no longer able to do that, and as a result, the PaCO2 is going up. Huh. A lot of people got this wrong. Yeah, RTA is non-ion gap, so I'm not sure why so many people picked that, but it seemed like a pretty obvious answer for me. Am I missing something here? Yeah, I have no idea. I feel like it's probably because most people just saw this and went just like, oh, metabolic issue. They didn't think about the pulmonary compensation, respiratory compensation. Management question, newborn, NRDS. This seems like a recurring theme. Let's see if I can get it right. Third time's a charm. Absent breast sounds on the left and clear breast sounds on the right. It seems like maybe she had that CDH, congenital diaphragmatic hernia, and for that uh, you'd have to surgically fix it. But it seems like we're not even trying to do that here. We're trying to buy some time. Chest tube's not going to do anything because it's not just air. Would you intubate? I guess you would, since she rolls pericarditis and no, heart's fine. Prostaglandin, U1A, PDA. I don't think the ductus arteriosus is going to contribute anything. Surfactant. No, 37 weeks. You should be fine, honestly. Broad spectrum antibiotics or intubate. Kind of like broad spectrum antibiotics because she's going to need surgery. And would you start that now, or would you just do it? Or I guess this is kind of an emergency situation. I feel like intubation cannot wait, whereas broad spectrum antibiotics can at least kind of wait. Yeah, so I'm going to go with intubation. Oh, wow, no one chose broad spectrum antibiotics. Okay, that's interesting. Mechanical ventilation should be used cautiously to avoid barotrauma. Vacuum mask valve ventilation is contraindicated because it pumps air into the GI. Oh, that's interesting. So I see. So like you inflate, you don't want to inflate the gastric organs, so you end up just pumping air into the. So you need to intubate them and not just bag them. Oh, okay, that's really cool actually. All right, broad spectrum antibiotics treat pneumonia. Uh, cool. I think first time I did this question too, I knew it was CDH, but I didn't know what the treatment was. Yeah, that makes sense. Decreased mortality, 44-year-old. Pancreatitis. ARDS probably. Yep. All right, so for ARDS, yeah, you want small tidal volumes to avoid distending the alveoli and making things, which kind of worsens the recovery. Uh, yeah, so preventing alveolar overdistension, since that tends to like expose more of the alveoli to damage. I guess this makes sense if you think about it, because ARDS is caused by kind of your alveoli, the surface, the lining of your alveoli reacting to getting injured. So it makes sense that you want the alveoli to be closed, or at least as closed as possible to avoid excessive damage while still oxidating them. Complications, pediatrics, drown. Yeah, so she's at a risk for ARDS, no doubt about it. Arrhythmia, no. Cerebral edema, that can happen if there's some neurovascular injury. However, if you can rescue breathing, the patient was, yeah, this is only 5 minutes, so I don't think there's going to be any neurological injury from this. Pneumonia, maybe, but because it gets rid of all the protective mucus, but there's not going to be shocked. Yeah, I'm going to go with respiratory insufficiency on this one. Seems like ARDS is going to be at least uh, can happen after you get exposed to cold water. Oh wow, pneumonia was a way more popular answer, 49%. Wonder why it's not. So it's like when you're in contaminated water, but not in a swimming pool. Okay, that's interesting. I always thought it was just because like the water washed away all the protective mucus, but it seems like it's actually the pathogens in the water that are related to the pneumonia. Hmm. Still think I'm right? No, I don't think I'm going to mark this one. Etiology, pediatrics, 18-month-old. Look at that jaw. Seems kind of hypoinflated. Don't know. There's maybe some kind of obstruction on this left side. An hour ago, so pretty acute. Pretty acute neck. Prolonged expiratory phase. Hyperresonance to percussion on the over the right chest. All right, so the right is pretty hyperinflated. Wheezing without crackles for the left lung, cool. Without the right lung. The left lung is clear. Huh. Without crackles or wheezes. I don't think it's anaphylaxis. It'd be weird to see this kind of difference between the lungs. Asthma is sudden onset. Yeah, sure, but again, you wouldn't see this type of difference between the two lungs. Bronchiolitis, no, it's entirely different set of symptoms. Foreign body aspiration, maybe pneumonia. You wouldn't present this acutely. Pneumothorax. Let me take a look. Yeah, I see lung markings all the way out here. Yeah, this is not pneumothorax. So yeah, I think this is just foreign body aspiration. Good. Management question: 64-year-old with worsening cough. So you see pretty significant leukocytosis here, very acidotic. Little bit of air trapping, but not too bad. Poor inspiratory effort, right lower lobe consolidation, full management of this patient. I think there was one medication you just don't admire with pyridostigmine. I think it's some kind of antibiotic. One of them immunoglycosides, for some reason, it interacts with pyridostigmine. Uh, yeah, no real signs of impending respiratory failure or anything, so I wouldn't anticipate. When I discharged her, 64, myasthenia gravis, febrile, curve, she's uremic. Not really. Uh, I feel like this is a pretty significant comorbidity, honestly. I mean, difficulty choking on solid food. Yeah, I think she needs to be hospitalized. So she doesn't seem confused. Or not. There's no anemia. Renal looks fine. Uh, no signs of sepsis or anything. But kind of given the comorbidities, I'm still more inclined to hospitalize her. Um, no, I don't think hydrocortisone is going to do anything. Her pressures are fine. Administer additional pyridostigmine, maybe, but I feel like that's not the next best step. You would want to get a cultures of someone like this and start treatment, levofloxacin. Yeah, it sounds like the proper treatment. Huh. Oh, myasthenia. Oh, jeez. All right, so myasthenia gravis, myasthenia crisis, significant muscle weakness resulting in respiratory failure, which can cause body infection. So impending respiratory failure. Okay, I see. So I guess I said there was no respiratory failure based on the arterial blood gases alone, and that's not what you're supposed to do. There are clinical signs as well, such as tachypnea, shallow breath, muscle weakness, difficulty to clear secretions. All right. Yeah, so they also need a plasma exchange or IV, IVIG or high dose corticosteroids as well. Okay, wow. So I guess I just didn't really take into account the more subjective or at least non-ABG manifestations of impending respiratory failure. So that's why I got this one wrong. Pediatrics again. I feel like these questions are disproportionately pediatrics. Um, yeah, I need to refresh my pediatric pulmonology skills. Prematurity, RDS, 28 weeks, cyanotic, coarse breath sounds, CPAP, NICU, intubated. Yeah, you can see the error of bronchograms, but that's about it. Risk factor for the development of RDS, antenatal corticosteroids, this decreases the risk, IUGR. Not sure. Oh, geez. None of these. What is an independent risk factor for NRDS? Ah, shucks. It's just lung immaturity, right? And which one of these causes immaturity? No, no, maybe, no, maybe. Yeah, I'm gonna go with maternal hypertension. Nope, it's maternal DM, diabetes. Fetal hyperglycemia, fetal hyperinsulinism, okay. High levels of circulating insulin, antagonized cortisol, block, jeez, maturation of sphingomyelin. How is anyone supposed to know that? 40% of people got it right too. Oh wow. So intrauterine stress stimulates early fetal lung development, and so you can't stress them. C-section without labor also increases RDS. Wow. Okay, this is really counterintuitive stuff, and I don't remember this question at all. So stress actually decreases the risk of RDS. Okay. Super counterintuitive. I guess I just didn't know that. This is clubbing, adult, pathophysiology. Yeah, this guy has cancer. COPD and cancer, airflow is not related. Hypoxemia. Yeah, I think this could be related. Well, hyperinflation, no. People on asthma patients don't get clubbing. Occult malignancy, no, that's not a sign. Pulmonary hypertension, no, those people usually don't get clubbing. People with hypoxemia, which is wrong. The 53% of people chose it. Can activate local dilation, increase blood flow to the distal portions of digits. However, hypoxemia in absence of malignancy is not associated with clubbing. Because I always thought it was something to do with the hypoxia-induced growth factors that cause clubbing. Yeah, because like cystic fibrosis, for instance, isn't that just because of like chronic issues with hypoxia? No, maybe karyocytes entrapped in the distal. Okay. So what they're saying here is that megakaryocytes go into systemic circulation, but I don't understand why Only cancer causes that. This person obviously has COPD, and not sure why I got that one wrong. I think I just didn't know the part about making karyocytes, maybe. Got that question. Diagnosis: 24-year-old. All right, so we have a pretty bad trauma case here. Uh, Kind of heart failure. You can see that there's not enough getting back, but at the same time, no signs of trauma. So I think something's happening within the mediastinum that's causing this. Also, a pacification of the left hemithorax, wider mediastinum. Was there any breath sounds over it? No, diminished on the left. So maybe he has some kind of a hemothorax, but that's not even in the answer choice. All right. Bronchial rupture. No, you'd see air, but you I feel like it wouldn't be this bad. Wouldn't explain the. Wait. Uh, yeah, this can cause air, but it wouldn't be this bad. Diaphragmatic rupture. I feel like you see a lot more. You definitely see it on chest X-ray. Bronchial rupture. Again, you can see air in the mediastinum because of this, but I don't see it causing such bad hemodynamic issues. Contusion, it wouldn't cause the wider mediastinum. Myocardial rupture, no, you'd be dead. Uh, Neurogenic shock, that would explain a lot of hemothorax. The only thing that kind of ties it together is kind of the thoracic aorta injury, because that can cause that can go back to the coronary sinus and cause wider mediastinum, and it can also compress the lungs to the extent that you would have diminished breath sounds. Would also explain the hemodynamic instability. We'll go with this one. Oh, so it was a hemothorax. Okay. Yeah, so I think I got it right. I'm not going to mark this one, but makes sense. A lot of people got it right. It was an easy question. Thoracic fusion, 47-year-old woman, pathophysiology. LDH is super high. Leukocytes, protein, all that good stuff. So clear exudated diffusion. Culture shows nothing, which is most specific. All right, so exudated is like usually some kind of inflammation, but there's no microbial transaction. Displacement of this is transudative, obviously. Hydrostatic pressure, also transudative. Impaired fluid drainage into lymphatics. I don't know if this would be transudative or exudative. Decreased oncotic pressure in pleural capillaries. I don't see why this would happen. Yeah, so the only one that kind of makes sense to me is E, which is wrong, but the most commonly picked one. And as it turns out, there is displacement across the intact pleura. Inflammatory increase in vascular membrane permeability, the Light's criteria, uncomplicated involves displacement of sterile exudate into the pleural space, relatively low. Okay, that doesn't explain anything though. Vascular membrane permeability, yeah, I know. Malignancy and pneumonia, yeah. Uh, Parapneumonic effusion, yeah, I know that. Sterile exudate across the intact pleura. Oh, okay, that's what they mean. So there is exudative fluid too. It's just that the effusion is. Wait, what? So, okay. So I guess there's exudative fluid in the lungs and it's just getting displaced. Okay. All right, and B is wrong because we're not concerned about lymphoma and we get more cells. But again, whatever. Castle phase, 50-year-old. All right, so this is a lightheaded patient. Notice how slow the sodium is and how high the potassium is. This is PAI, no doubt about it. I'm sorry, this is some kind of primary adrenal insufficiency. The question is why? He has had fevers, cough, medical history, anywhere from Southeast Asia. I remember this question. I think I was thinking tuberculosis for this one. Airspace disease, airspace disease, yeah. So I thought it was tuberculosis, uh, or some kind of infectious disease, but no, like apparently miliary tuberculosis for that. So it's totally just turned out to be autoimmune, just like everyone else's. Wait, but that's not an answer either. I don't think he has a brain lesion. Uh, yeah, this is primary, or else potassium wouldn't be elevated, right? Potassium is defined as what? Yeah, so infectious adrenalitis. I'm still kind of thinking that mycobacterial pericarditis. No, I feel like that his neck vein is pretty distended. Perineoplastic. I don't know anything else, so that would explain the eosinophils. I don't know. I'm not suspicious of cancer. I guess it could metastasize to the. Actually, yeah. Cancer could metastasize to the adrenals, but kind of a low risk patient. I don't know what cancer. It's not likely. Pulmonary strongyloides low. No, this is an adrenal issue. Strongyloides wouldn't do this. So this is miliary tuberculosis. Okay. So this is PI. I guess my reasoning was still correct all along. I second guessed myself too much. And this question, I'm going to mark it because I literally just did this one earlier today. So when you intubate, pushing, you're essentially forcing the diaphragm down. That decreases right ventricular preload. And because there's less preload, there's also the right ventricle cannot pump nearly as much blood into the lungs. As such, there's decreased left ventricular preload. I thought that pushing air to the lungs would make the fluid go. This is what pulmonary edema or pulmonary hypertension. I don't remember. Yeah, I think this is flash pulmonary edema. But yeah, no. And then when you because now that all of a sudden you have pressure in the thoracic cavity, your baroreceptors in your neck sense high blood pressure, so they actually fire less and decrease the systemic vascular resistance. So afterload actually goes down. 50% got that right too. It was so confusing to me. I guess I don't know how so many people got it right. Management, 38-year-old. All right, seems like, oh boy, bacterial or viral pneumonia. She's coughing a lot. I do a bronchoscopy. However, it's the opposite. It sounds like she just coughs so much that she irritated her bronchus or trachea. Uh, no, bronchoscopy, I really doubt it. She keeps on bleeding, sure, but not right now. CT, no. It's not too far. Chest X-ray showed feels clear lung fields. PFTs, no. Sputum, no. It's not at high risk for tuberculosis. Sputum cytology, maybe. Sputum gram stain culture. Again, maybe symptomatic treatment only. How sick does she look? Yeah, no, her lungs are fine, so this is still like a bacterial URI. Uh, yeah, I don't think I do sputum cytology or culture for this one. I'll probably just do symptomatic care only, which is the right answer. Yep, this is acute bronchitis. Cytology is for cancer. Yeah, so acute bronchitis, maybe some blood. It's self-limiting. All right, cool. So yeah, that's going to be it. It's 1 hour and 3 minutes later. My voice is starting to die out. So that's going to be it for pulmonology reviews today. So just kind of going over everything at the very end. First question, this is a pediatric pulmonary question that I missed. Got it wrong because I confused and croup and epiglottitis. Epinephrine is for croup and immediate intubation is for epiglottitis. All right, number 3 I got wrong. This is the question about adult. What is this question about? I don't remember what this question was about. All right, this was a post-surgical, this was a diagnosis question regarding PE. And I forgot the fact that she had cancer and PE was most likely diagnosis, so I undercalculated the raw score. All right, this question, yeah, another pediatric pulmonology question. I didn't really understand the presentation of respiratory distress syndrome, and that caused issues for me. Yeah, and I didn't understand the meaning of error prone programs. This didn't look bad enough to be ARDS, but it is ARDS. And persistent pulmonary hypertension is just completely looks completely normal. Geez, another one, another mistake. Geez. Yeah, for this one, I forgot the fact that she was apparently in really severe hypotension. You can get bounding pulses, and I just didn't expect that. And in this question, this was that obstructive sleep apnea due to tonsillar hypertrophy. For choanal atresia, it means that whole thing is atresia. There's the entire thing is blocked. Unilateral causes different symptoms, and the fact that he breathes through his mouth is more due to the tonsillar hypertrophy than any type of choanal atresia. And also, choanal atresia is exclusively in neonates, so you can't develop it later on. Right, yeah, this was fat embolism question. I didn't know the timeline, 24 to 42 hours, so I got this one wrong. All right, this was an infection question, neutropenia patient with pneumonia. Remember, invasive aspergillosis has those halo-like structures. Halo, what are they called? Halo signs. This one I got, remember, Staph aureus is more common in children because they pick their nose and get viral infections. Pseudomonas is more common in adults because they go to hot tubs. So yeah, it is, I guess, reasonably, it is common for 30-year-olds to come and present with asthma to be diagnosed with asthma that presents as coughing only. And if there's that, you do PFTs. Got it wrong because I didn't expect asthma to be diagnosed at such an age. Ventilator question, I just memorized. Um, Permissive hypercapnia is the thing, and you want to get rid of pulmonary edema via the fluid balance, not via anything else. Acute COPD exacerbation, you want to give IV steroids. Do not use inhaled corticosteroids. It's not going to work here. It's not going to work in the acute setting. All right, so for patients, when deciding whether or not to intubate, remember that the subjective signs and the object and it's pretty much don't just depend on the ABG. You have to take a look at muscle weakness and the patient saying that they're tired, shallow breaths, and inability to clear secretions. Remember all that stuff. All right, and for RDS, remember that stress decreases the risk of RDS. So any type of growth restriction or maternal hypertension, all that stuff stresses the infants, which actually decreases the risk of neonatal respiratory distress syndrome. Maternal diabetes ends up actually increasing the risk because it doesn't stress the patient. All right, this is a BS question about clubbing. So in clubbing, you see megakaryocytes going to the distal extremity, going to the fingertips and getting stuck there, and that's what causes the actual clubbing. Hypoxia has nothing to do with it. So all those hypoxia-induced growth factors that I've heard about or in class actually are not the underlying etiology. This is a pretty recently updated question too, so I guess they might be aware of the complaints. All right, so in a parapneumonic effusion, the fluid from inside the lungs, the interstitial fluid, which is obviously very badly inflamed, can cross the intact pleura. I don't know how that works. I really don't, because the pleura is supposed to be kind of impermeable. Inflammatory increasing fast. Okay, I see. So the pleura when there is so much inflammation, the pleura becomes permeable. So even though it's intact, it's still very permeable, and therefore the inflammatory fluids can leak out. And lastly, for this, when you intubate or give a positive pressure ventilation, you remember you're decreasing the afterload since you're triggering the baroreceptors, and you're also decreasing blood to the lungs. As a result of that, you're decreasing the preload, left ventricular preload. All right, that's going to be it for the summary of the pulmonology questions I've missed, and probably make another series of videos for other questions as well. All right, that's going to be it.